This is the second series of slides on how to manage appropriately a 10-minute headache presentation. We now move on from a new presentation to the much more challenging problem of a chronic headache associated with complex multimorbidities. And this is a sort of typical case that we will be confronted with, constant pain for some time, not sleeping, no clear features to the pain, pains all over, abdominal pains, pains all over the body, already on antidepressant therapy with a history of anxiety, and inevitably worried that they have a brain tumour because always their friends seem to have had a brain tumour or something's brought that to their attention. So I want to offer you some tips to try and navigate your way through this challenging problem, which can be hugely rewarding to treat. And this is the sort of pattern perhaps we will be seeing of the headache. And our strategy now shifts very markedly from a new headache presentation to a very different approach. So here we have to unpack a complex problem rather than a simple diagnosis. We want to offer a story, coherent story that makes sense and holds together. We want to manage the problem holistically with appropriate medical interventions, but also utilizing the body's intrinsic ability to heal itself. And we want to do this within the context of a therapeutic consultation. So a very different change in emphasis. Just for completion, we need to be mindful that there are a number of other causes of chronic headache, which I've listed the main ones here. But with a presentation like this, you're 98 to 99% certain to be looking at a picture of chronic migraine. Chronic migraine, formally diagnosed as headache on 15 or more days of the month, of which 8 are migrainous in character. Chronic migraine used to be called transformed migraine, which in a way I think is almost a better term. It's very rare that chronic migraine originates de novo. It tends to build up over a long period of time from low frequency to high frequency, then to chronic under various physical, psychological and social stressors. And as the headache frequency builds up, so does disability, reflected in more treatment resistant headache, invariably medication overuse headache, and increased multimorbidity, a whole combination of other diseases and problems that go with it. So here's a guiding principle to think about, to negotiate the interface between medical science and the body's intrinsic ability to heal itself, and to hold a space where healing can occur. So what do I mean by healing? This isn't some sort of wacky concept. I'd like to go back to the Greek root of both healing and health, which is holos, which is whole. So healing is defined as creating a context for the body's intrinsic ability to regain its normal function. And we don't have very far to go to look for this. We can see this in all the migraine studies, in fact, and in fact every study that has a placebo rate, which is virtually all diseases. Here is the response rates of the new drugs that have been introduced, made a very significant difference to many people's lives, the gepants, for the prevention of migraine. But you can see that although there are very good response rates for the drugs, the placebo rates are also quite high. Now, in all these cases, the difference is statistically significant, and that's great. We can get on and market and use the drug. But what we don't seem to be saying is, well, hang on a sec, what's going on here? And how can we use this body's ability to heal itself in conjunction, in addition to the active drug? Whereas what we tend to do is shove the placebo under the carpet and see it as an otherwise inconvenience in a perfect study design. We should be asking ourselves, what is this reflecting, and how can we mobilize this effect? So step one, and I'm going to suggest that you offer this approach in a context of, it'll be a minimum of 3 10-minute consultations. You may like to ask the patient to come back for a double appointment. But this is step one, the first appointment. The first most important thing you can do is listen to their story and take them seriously. Witness their predicament. This is hugely therapeutic because no one would have actually listened to them before or taken them seriously. They've been pushed around from pillar to post and basically given up. So this is hugely therapeutic. Often the patient's in tears. The whole thing is, you're in tears, everyone's in tears, and you can be guaranteed that you're on the first step of the road to recovery. So that's a really important first step. Step 2, we've got to get the basics out of the way. A history. I'm not going to go into the history in any more detail, but I think there's 2 key questions to ask here. How many types of headache do you get? And you need to flesh out medication overuse headache, which will be ubiquitous. What painkillers are you taking? Medication overuse headache will occur if you take any painkillers, any anti-inflammatories, on more than 10 days of the month, or any triptans on more than 8 days of the month. And most people with chronic migraine will be having medication overuse headache. The important question is how many types of headache do you get? Because when these patients present, their headache's all over the place. You can't make head or tail of it. And usually there are 3 components. There will be a background tension type headache, also exacerbated by medication overuse headache. There will be a migrainous element on some days. And very often they also get idiopathic stabbing headache, these short, sharp jabs and jolts. And this can present a very challenging picture unless you ask the patient how many types of headaches do you actually get and go through these different types one at a time. And invariably one of the types will be migraine, in which case you can be confident that everything is part of what I call the migraine spectrum and make a diagnosis of chronic migraine. You do your neurological examination. We looked at a 3-minute neurological examination signposting in the first series of talks on the acute presentation. You reassure that there is no evidence of serious pathology. The problem's been going on for too long really to indicate anything serious underlying, and you reassure them that they don't need a scan. And you could also do some basic bloods just to get that out of the way as well. So that's the basics. And once that's all been sorted, you've made a diagnosis, you can then move on with addressing the problem. Step 3 is an important one. I think you need to establish realistic expectations, and here's the deal. You're going to offer them an understanding what is going on. We're going to set that within a coherent story. We're looking for control, not cure. I like to think of this as a shift of locus of control. So for most of these people, their migraine is in control of their lives, and through an understanding and appropriate treatment, you're going to shift that control so they are in control of their migraine. It's not going to happen overnight. There's not going to be a quick fix. Here's a pill, off you go, and things are going to be fine. And it's also going to need commitment on their part. Step 4 is to start them on appropriate medical management. We're very fortunate now that we've got some really good drugs that we can use that can get the ball rolling. And we need to address the medication overuse component of headache. I'm not going to go into that in any more detail, but it's probably best to get them on a preventer first, and then you have to stop. It seems that going cold turkey is the best way forward to address this problem of medication overuse headache. Step 5, and now you're probably getting them back for their 3rd consultation. We need to get the multimorbidities out on the table, and this is a really important contribution to the distress that these people are having. Migraine has got a huge number of comorbidities. Here are some of the main ones. Some you will be aware of, some you will not, and will have to look out for. So anxiety and depression are the most common. With anxiety, you've got up to 5 times the likelihood of having anxiety with migraine than without migraine. And you will almost certainly be aware that the patient will be having this and may well be already on treatment, but you certainly need to ask about that. Then there's a second group where you may not be aware of the relationship, and you may need to ask about this. Fibromyalgia is very common. All bowel issues are more common in people with migraine, but particularly irritable bowel syndrome. Insomnia is virtually ubiquitous, and this can be exacerbated both by anxiety and depression, but also by restless leg syndrome, which is comorbid with migraine. No one will probably tell you that they have water running or spiders crawling up their legs at night, they'll probably think you feel they're mad. But you need to ask the question: do they move their limbs at night, particularly their legs? Can happen in the arms. Do they have funny feelings like water or spiders creeping up or running down their leg? And that can be treated appropriately. Asthma and epilepsy are comorbid, and these would probably be previously diagnosed and already on the patient record. You need to get any life traumas on the table. These will again be ubiquitous, and in particular significant adverse childhood events. Virtually everyone with chronic migraine will have a significant adverse childhood event or some stressor during the childhood period, and you can refer them in the first instance to the local talking therapy team for assessment. Then another important one that we're becoming increasingly aware of is people with lax joints, part of the Ehlers-Danlos spectrum. It's a really interesting group of people who we don't really fully understand, but we are recognizing, not infrequently in the clinic, a combination of chronic migraine, Ehlers-Danlos spectrum, POTS syndrome, mast cell activation, and a whole range of problems that arise from an autonomic dysfunction. These are probably all held together by some common genetic precursor, but it's important to identify them because these people would have been pushed around from pillar to post. Everyone would think they're mad, but they're often chronic fatigued. Sometimes the POTS can be quite severe and they find it really difficult to get out of the chair, and these people are really struggling. So you need to have a look at their joints or ask them if they have loose joints, and if they are, explore those areas. Neurodiversity is comorbid with migraine. You have about a 1.5 times more likelihood of having a neurodiverse problem. You may not want to go there now. You've probably got enough on your plate without opening that diagnosis, so you may just like to put that on hold for now. So those are the migraine comorbidities, and probably that's going to take you a good part of your second consultation. So bring them back for the third consultation, and step 6 is putting the whole thing together in a story that makes sense. So here's the backstory, here's the medical backstory, these 3 key concepts that are emerging. Firstly, the brain is now seen more as a predictive organ. This is feed-forward control rather than feedback control. So homeostasis, the concept of homeostasis is becoming to be complemented or possibly overturned by allostasis, which is the brain predicting what's going to happen on the basis of stored models and changing those models so that our criteria is a minimization of predictive error. The second concept is this concept of embodiment or multi-scale architecture. The brain and body are best viewed as one complex unit. And the third really important construct is that we have a number of stressors in life which lead to a chronic inflammatory load or allostatic load, which impacts upon the cognitive ability of the brain, or specifically the brain's predictive ability and ability to minimize predictive error. So that's the emerging backstory, and the key theme is one of disconnectedness, which is, I think, one of the themes of our modern age. So what is the problem with being disconnected? Well, to minimize predictive error, we need to optimize information flow, and to optimize information flow, we need to ensure that the complex systems of which we are made and our complex interaction with the environment, the dynamics are coherent. We are connected optimally and appropriately, which will optimize our information flow and minimize our predictive error. Now that sounds a bit of a mouthful, and indeed we'll move out to deep water quite quickly, but what does this mean from a practical perspective? Well, this means that many of us, and indeed these people with chronic migraine, are often disconnected from their bodies, disconnected from each other, disconnected from our authentic selves, disconnected from our unprocessed emotions, disconnected from our environment. So if you like, you could say that the whole presentation of this complex chronic migraine is one of disconnectedness. This is not just some arbitrary thinking. This is underpinned by some hard theoretical considerations, and we get into deep water quite quickly. But if you are interested, I'd signpost you to the work of Michael Levin and Carl Friston, who are arguably two of the leading thinkers, I think, in biology, biological systems thinking, and neuroscience at this current time. But that's really not a narrative or a story we need to weave for our patients. Let's get back to something simpler. So why do I get migraine, doctor? Well, here we are in simple terms. People with migraine have brains that are hypervigilant and hypersensitive. And when we evolved about 1 million years ago on the plains of East Africa, this was evolutionarily advantageous to have a brain that was hypervigilant and hypersensitive. We could spot the lion chasing us, we could spot our lunch in the long grass. Fast forward 1 million years, and these big, broad outlines of the horizons, the gentle breeze blowing, the soft shapes, have been overtaken by a cacophony of shapes, sounds, angles, colours, and basically the brain gets overloaded and has to shut down. I think this is a good starting point to understand the migraine process. We have a genetic disposition to a hypersensitive, hypervigilant brain, which was once an advantage to us, but now is disadvantageous. The second part of the story is to think about how stressors in our lives can lead to this chronic inflammatory load. So when we get a stressor, we have this inflammatory reaction set up. We activate our autonomic nervous system, our hormonal pathways, and this complex cytokine system. And initially, again, 1 million years ago, this evolved when the stressors were fairly straightforward. They'd either be infection or some physical assault to instigate repair and defense. But now we have this chronic inflammatory response for a whole array of physical, psychological, and social stressors, of which indeed migraine is one. Migraine is an inflammatory process. And this is a wide range of things that can cause this, including poor social circumstances, poor diet, particularly ultra-processed food is great for instigating inflammation, lack of exercise, obesity, gut biome, and traumatic life events, particularly significant adverse child events when the brain is far more susceptible to stressors. I try to avoid the word stress. I like to talk more about the word stressors and chronic inflammation, although I can't resist the term stress bucket because I think it's a very appropriate one. We are all carrying our stress buckets around with us, which is filled by these various stressors. And as our stress buckets become overwhelmed, the important point to make is that the stress is kept throughout the whole, it's held throughout the whole body, not just in the brain. The body keeps the score. This chronic inflammatory load can impact upon the way the body functions, the way the brain interprets signals coming from the body, and our cognitive functioning of how the brain actually works, in particular its predictive processing ability. This in turn reduces the migraine threshold, gives us more physical problems, psychological problems, and social problems, particularly how we begin to see ourselves and react to others. This leads to more inflammation, so the whole thing gets carried away in this positive cycle. So that's a simple story that you might like to think about to share with your patients with chronic complex migraine. So where do we go next? Well, we need to start thinking holistically. Drugs are not the only answer. And this is the framework I'm sort of working around at the moment. It's 4 pillars underpinned by one foundation. So the 4 pillars to a holistic approach are the medical approach. Do I have the best evidence-based medical treatment? And as I said, fortunately, there's a whole array of treatments, electrical treatments coming on board more and more as well frequently, that can support us here. The second pillar is managing our external environment. Do I have an external lifestyle that is beneficial to my migraine health? Am I keeping things as constant as possible? Have I got an adequate diet? Have I identified any specific triggers? Have I got adequate exercise? Is my gut biome appropriate? Am I getting enough sleep? These are things that you need to address for that second column. The third column is managing our internal environment. And here the key question is, am I supporting my body to heal itself? This is where we start thinking about the concept of healing. Are my body systems interacting in a way that's coherent? And here we would start thinking about a number of holistic practices, mind-body practices, breathing approaches, body awareness approaches, a whole range of techniques, most of which have been taken in from Eastern philosophical practices and have a developing evidence base to support them. And finally, am I managing the interaction between my internal and external worlds? How can I improve the harmony between my internal and outer worlds? And some of the simple things we'll be looking at here is nature immersion. Lots of evidence to suggest that nature immersion has beneficial effects for well-being, and as does social engagement. So we'd start thinking about how we're interacting between our internal and outside worlds, underpinned by a foundation of reframing or thinking about, or the need to reframe our sense of self. What we find with people with chronic migraine, they're angry, they're frustrated, they're bitter, they're embarrassed, they're ashamed. And this impacts very much on the way they see themselves. So we need to start unpacking this and try and help people find their authentic selves. And again, there are a number of techniques, all of which have been introduced into mainstream medicine, such as acceptance, commitment, self-compassion, that can help move this agenda forward. So quite a large array of things we can do. So how do we go about addressing that rather overwhelming constellation of interventions? Well, help is at hand. I've put together on this website, holisticmigraine.org.uk, a handbook which contains both the stories that we've been talking about and a wide array of interventions across those 4 pillars and that underlying foundation. The whole thing is underpinned by an appendix where all the theoretical stuff is there, tucked out of the way if you want it. It's accompanied by, I think there's 7 30-minute online talks. So it's not sort of a straightforward, here's the answer and off we go. It's quite a sort of challenging construct, but it's something that you might like to direct your patients towards to have a look at. And you can download the whole thing for nothing, it doesn't cost anything. This is going to be ready. It's up and running, but it's not. I haven't actually put everything up on it. It'll probably be up and running. Where are we now? We're in October. It'll probably be ready by November. So that's something you might like to look at. So finally, step 7. I think you can sit back and feel grateful that you've had the opportunity to reduce someone's suffering very significantly. This is one of the very few areas of medicine where you can really change people's lives around, and it is very, very rewarding to do. Just by way of some resources, this is a resource I alluded to in the first talk on the headache consultation. This is a website, headachegp.org.uk. This is run by our GP with extended role group of the British Association of the Study of Headache, where we put in various resources for various people who are engaged in the management of headache. I've just finished off the support for schools. If anyone's interested in that, that's now complete, and we're beginning to populate support for primary care practitioners, so you might like to look at that. And if you want to know anything about headache in a little bit more detail, here's a short advertising break. This is the Oxford University Manual of Headache, which I edited with Peter Goadsby, which is a very concise pocket guide to everything you need to know about headache if you're interested in taking this area forward. So hopefully that has helped. It's a challenging problem, but one that's very well worth spending some time because it is very rewarding.